Hey, it's Wong here. Let's do some practice questions together if you are studying for the CHG exam. Now, I am going to warn you, this video is really boring unless you want to do practice questions together. These are questions specifically from my book and from the Exam Prep On Demand program. Now, if you haven't heard, I've got a brand spanking new book out. It's called Hand Therapy Exam Success, the ultimate book of practice questions. It has all the latest information. It uses the HTCC blueprint as well as my frameworks I've developed, all to help you structure your studying. Now take a listen and let me know what you think.
What functional impairment is a 35-year-old male expected to have after a low ulnar nerve injury resulting in the loss of intrinsic function in the hand? Inability to perform tripod pinch for feeding and dressing. Let's see, tripod pinch. Tripod is also another word instead of three-jaw chuck, right? Inability to tripod pinch. Difficulty in encircling larger objects, putting things in your hand and moving them around, right? Increasing sensitivity to temperature changes on the ulnar side of the hand. Increased sensitivity to temperature changes to the dorsal side of the hand. So those are our choices. Functional impairment of a 35-year-old expected after a low ulnar nerve. So in your head, you're like low ulnar nerve injury resulting in the loss of it. So what does low ulnar nerve look like? Right? So then we can rule out a couple of things. Definitely we can rule out D, right? And we can rule out C, right? Because ulnar nerve there are some sensory changes, but they usually don't have sensitivities to those. So it's going to be between A and B. Yep, B. So it interferes with that in-hand manipulation, right? A 37-year-old female presents with an ulnar nerve palsy. What test would be performed at the evaluation for a loss of the adductor pollicis? A Wartenberg sign, B a Froment sign, C a Ewald sign, and D a Tinel's. So if this is an ulnar nerve palsy, right? An ulnar nerve palsy, then I can get rid of Tinel's and I can get rid of Wartenberg's. And if I didn't know what Ewald's is, but I knew what Froment's is, what's your answer? Froment's is a pinching one. Wartenberg's sign is the abduction one. Tinel's sign is actually Tinel's, sorry, I don't know why I made the assumption that was carpal tunnel. But Tinel's sign can be done anywhere where the nerve is. So there you go. See? Freaking assumptions. But the Tinel's sign is more like the sensory versus like a motor. What's your choices? The answer is B. Froment sign, because a Froment is to pinch a piece of paper and pull it. And if they go into a lot of IP flexion, that is a sign that the adductor is not working. All right. Which of the following best describes a neuropraxia according to Sheedan's classification of peripheral nerve lesions? Okay. Complete disruption of the nerve continuity with loss of axons. Client may benefit from tendon transfer surgery. What best describes the neopraxia according to this particular person's classification of peripheral nerve lesions? Okay, all right. So complete disruption. Okay, B is interruption of nerve conduction. Axon continuity is intact. Axon continuities is intact. Client benefits from conservative therapy and spontaneous recovery is quick. C is disruption of the axon continuity with intact neural tube. Regeneration is slow. Client would benefit from orthotic intervention and therapy for spontaneous recovery. D is axon continuity is intact. Client will benefit from orthotic intervention and spontaneous recovery is slow. All right, neuropraxia, I would need to know what that is. Selden's classification of peripheral nerve lesion, I would need to know them. Does anyone know this? So I don't know it, but all three choices, neuropraxia, right, isn't as severe, right? So I would say, okay, well, B, C, and D all seem pretty similar. So I'm gonna rule out A as the obvious one. Let's see, interruption of the, so then I would look at it and say which of these make sense. Like, let's say you don't know, right? B. All right, interruption of the nerve conduction continues intact and would benefit conservative and spontaneous is quick. Yeah, I would go with B too. Disruption, intact neural tube, regeneration is slow, would benefit from orthotic and therapy. So I don't necessarily think it's just from orthotic intervention, just because this is very specific, right? And these two have orthotic intervention. So yeah, I would go with B too. Let's see what the answer is. Oh yeah, we're correct. Boom, done. Yeah, so sometimes if you don't know it, you would want to take like as much of an educated guess as possible, and then I would look at the clues in the choices. Very good. Okay, in which type of peripheral nerve lesion are patients commonly referred for conservative therapy and tend to do quite well? Oh, come on. Why did I pick this one? It was easy based on the last question. Demyelination, neuropraxia, axon tomosis, neurotomosis. Mosis is like kind of like like something more severe, right? Demyelination is also more severe. So out of those three, yeah, they're more severe. So the answer would have to be A, neuropraxia. A therapist is preparing a 30-year-old female with a median nerve palsy for a tendon transfer. So this is a median nerve palsy for a tendon transfer. The therapist issued this orthosis preoperatively. So what is the purpose of this intervention? So for a median nerve, right? For a median nerve, obviously all the choices have opponent's plasty. So of course that's the surgery that we're going for, right? So the purpose of this intervention is to increase thumb abduction in preparation to correct the extrinsic flexor tendon tightness in preparation, to correct a first web space contracture in preparation, and to isolate the thumb in preparation. What do you think the answer is? What can you rule out already? So you'd have to know median nerve palsy, what causes, what would a median nerve palsy look like. So without a lot of thumb movement, the thumb gets kind of stuck in the palm, right? So you'd want to increase that thumb space. All of them are somewhat right, but you're not necessarily too worried about isolating the thumb, right? So we can rule that out. You could rule out to correct the extrinsic flexor tendon tightness in preparation. That's talking about like the thumb here. So you're left with B and C, I think. A and C as some of your options. Yeah. Some guesses on A, and here is, so A sounds really great, right? To increase thumb abduction. But C is the answer to correct first web space contraction in preparation. And if you correct the first web space, you essentially also help to put the thumb into abduction, and you can also correct any kind of extrinsic thumb flexion types of issue. So C includes A and B. A 25-year-old male 1 year status post an ulnar nerve injury is a candidate for a tendon transfer. And presents with PIP flexion contractures. So if someone is 1 year post and they have a PIP flexion contracture, then I'm going to assume that they have a claw hand deformity and that it's a low ulnar nerve issue versus like a high. Which of the following interventions should the therapist consider? Issuing an anti-claw orthosis, initiating serial casting on involved digits, low load prolonged stretching of involved digits combined with ultrasound, and aggressive blocking exercises. Which of the following interventions should the therapist consider? So this is for someone in preparation for tendon transfer, but they have PIP contractures. B. Yeah. So a claw hand orthosis is not quote unquote wrong to do, but once they already have the contracture, then the claw hand orthosis doesn't necessarily help in preparation. It was the thing to have been done from the get-go. A low load prolonged stretching of involved, like it's not that that's wrong, you can do that combined with ultrasound, but that's like between the two serial, the casting is like a better option to break through the contractures, right? And then aggressive blocking exercises won't help necessarily to decrease the contractures. Sorry, I should have. So the answer is B. B, to initiate serial casting. A therapist is evaluating a patient with an old high ulnar nerve injury. Evaluating an old high ulnar nerve injury. Which of the following should the therapist expect to see? Claw deformity, atrophy of the hypothenar muscles, flexion of the PIP joints in digits 2 through 4, and able to cross middle finger over index finger. Which of the following should the therapist expect to see? So an old one. B. B, atrophy of the hypothenar. So claw hand would only be seen for a low ulnar nerve. And then if you're able to cross your fingers like this, that denotes your intrinsics work. So if they have they wouldn't be able to do that. All right. A therapist is treating a patient with moderate severe carpal tunnel syndromes. moderately severe carpal tunnel. Therapist fabricates an orthosis for nighttime wear. What position should the therapist position the wrist and the MCPs? Right, so the wrist in 45 degrees of flexion, the MPs in neutral. The wrist in neutral and the MPs in 45 degrees of flexion. The wrist in 15 degrees of extension and MPs in 90 degrees of flexion. The wrist in neutral and the MPs in 90 degrees of flexion. What position would the therapist position the wrist? What do you guys think? You would rule out 45 degrees for sure. And even the extension at all. So you're left with B and C being your choices. B and C. B is the answer. All right, so wrist in neutral to offload the pressure on the carpal tunnel, and the MPs in a slight flex position, really to relax the intrinsic muscles, because in carpal tunnel, when the intrinsics are down quite a bit, the intrinsics will go into the carpal tunnel space. So like when you go and do a lot of squeezing, then the intrinsics will move into the carpal tunnel space. So you just have them a little bit out. 35-year-old school cafeteria worker is being treated for a weakness in her right dominant hand during tasks involving wrist and finger extension. Therapist suspects involvement of what nerve and area of entrapment? Areas of entrapment. Okay, so if they're having problems with wrist and finger extension, what is that? So anything related to extension would be caused by which nerve? A is the PIN and arcade of Struthers. B is dorsal radial. I think that's all wrong. The superficial branch of the radial nerve and forearm. C is the PIN and the arcade of Frost, and then D is the AIN and the carpal tunnel. So it's definitely not carpal tunnel. So if you get AIN and PIN confused, like I do sometimes, it would not be carpal tunnel, right? And then I would not think that it's a superficial branch, because that's a sensory nerve versus like having problems with wrist flexion extension, which is a motor nerve. So you're left with the PIN and the arcade of Struthers, or the PIN and the arcade of Frost. Let me see what you guys pick. C. Correct. It is C. The PIN and the arcade of Frost, because it runs, the structure is called the arcade of Frost. The PIN is a motor nerve innervating the supinator wrist extensors and digit extensors. Great. All right. A patient with a complete transection of the median nerve at the forearm presents with no signs of loss of thumb opposition or weakness in the flexion of the index and middle fingers. What is the likely explanation of this atypical presentation? Right, if it don't make sense. So A is Marinci anastomosis. I can't pronounce these things. B is the name of another, Baratini anastomosis. C is the Ricci Canelli Canelu anastomosis, and then D is the Martin Gruber anastomosis. I picked the shit because I didn't know it. So don't worry about these when you get them, right? You just want to pick what you do or recognize, right? So I haven't heard of A and B. It's either C or D. I kind of think it might be D, but I'm not sure. Oh, C. C it is. C, the Ritchie canoe is an anatomical variation where there is a connection between the median and ulnar nerves in the hand. And the anastomosis can sometimes allow for functional compensation in the presence of a median nerve injury, particularly affecting the intrinsic muscles of the hand and maintaining some level of thumb opposition and finger flexion despite median nerve damage. That is so cool. That's the body's way of having double of stuff. So yeah, when you see questions like this, don't freak out. Like, it's okay. It's okay. You might star it to come back, but take your best guess and then move on to doing other questions that you do know. Which muscle is typically utilized to restore wrist extension in patients with a low radial nerve palsy? A low radial nerve palsy. A is the flexor carpi radialis. B is the flexor carpi ulnaris. C is a pronator teres. And then D is a palmaris longus if present, right? So to restore wrist extension in patients with a low radial nerve palsy. So which one is typically utilized? The FCR, the FCU, D. Yeah, the pronator teres is too far up, so you could rule that out. Oh my God, I totally got that wrong. Pronator teres. I would have thought that the pronator teres was too high up. In each case, a pronator teres is used to restore wrist extension. Obviously, I got that totally wrong. A wrist flexor, FCR, FCU is typically used to restore finger extension. Finally, the palmaris, if present, is transferred to reroute the extensor pollicis longus. If the FPL is not present, the digitorum superficialis is the one to move. Oh my God, yeah, that's right. Totally, yeah, it is because like the reason why it is used, the reason why I thought it wasn't used is the reason why it's used. Oh well, there went that one. All right, that was a good question. What do you guys think of the questions so far? They've been really good, right? Let me know. I feel like the questions have been really good, very thought-provoking, and very applied. If the palmaris longus is absent, which muscle is suggested for rerouting to restore thumb extension? Oh, why did I pick this one? I already gave you the answer. Sorry, the answer was given in the in the explanation. All right, I'm gonna have to mix these questions up a little bit. All right. So, all right, let me just read the question just in case. If the palmaris longus is absent, which muscle is suggested for rerouting to restore thumb extension? A, the flexor carpi radialis. B, the flexor carpi ulnaris. C, the pronator teres, or D, the flexor digitorum superficialis to the ring finger. And the answer is D. What motion would not be present during a physical examination of a patient with an acute high median nerve injury? So an acute high median nerve injury. thumb IP flexion, digit flexion of the DIP flexion of the fourth and fifth finger. Okay, so it's saying median. Okay, forearm supination and thumb abduction. So then this would make you think, okay, so that's why I went back to the question. It's a median nerve. And then so B is all about the ulnar nerve. So that is already crossed off, right? Thumb IP flexion, thumb abduction,